Hello, how are you today? I'm really happy to be here, and what I want to do is start off this session with just a little background. Why do we care about the technology behind the measurements of DLCO? And so just why accuracy and why precision? Why does anybody worry about that? So I'm just going to quickly go through this, and it'll be a little bit fast. We have different ways of looking at accuracy and precision. And this is just a little dart. So if you're both hitting the bullseye all the time, which is the accuracy, and they're all clustered around the same thing, that's precise. So we have accuracy and precision simultaneously. This is an ideal world. Next, we could have poor accuracy but good precision. In other words, everything's reproducible, but we get the wrong answer. So, and finally, we have poor accuracy and poor precision, which is we're not even getting the right answer or close to it, and then we get a different one every time we make a measurement. That's not what we want. So, why do we care? For diagnosing patients, primarily, accuracy is really important. If you don't have an accurate measurement of somebody's weight or their cholesterol or their blood pressure and so forth, you'll end up making an inappropriate decision about therapy going forward. And that inappropriate decision can be, I don't do any therapy, or I do dramatic therapy, and it's all based on a number that is not accurate. And when we actually see patients for the first time, whether it's for all sorts of disease states and so forth, we compare them to a reference value. And the reference values are typically made with really the best devices out there available at the time the reference was done. And then if we have a device that doesn't match the same accuracy and precision of the reference, then again, we're led astray in making that initial assessment of a patient, whether they're in the normal group or an abnormal. Inaccuracies, they again, as I mentioned, they lead to misdiagnoses and can have large consequences for the patients. Accurate measurements give confidence when somebody knows that their device is accurate and they can rely on that number being accurate from one test to the next to the next. So it makes a big difference in the confidence that the clinical physicians make when they're making decisions. So here's a little example of different accuracies that were measured in a series of devices in 2006 and 2007, published in 2007. And what we see is there's some very large differences in the relative accuracies of all sorts of measurements with a spirometer. So we can see as a percent deviation, we're up to 3-4%. Other devices are stable over time. And we see big differences in different measurements like peak flow and some really dramatic differences in the FEF 25-75 from different devices. And so just the accuracy alone can change dramatically with which device is out there. So verifying that a device is accurate and precise is really important. So having some assurance that the manufacturers and maybe the approval agencies have actually considered this is a good thing. Thinking about accuracies again, I just want you to think about confidence here. The confidence with which we make decisions. If somebody comes in and they run into the office and they're going to have some spirometry and they got on a pair of jogging shoes and shorts and they just came in from a 10-mile run and they're breathing great, you're going, oh, they're probably in pretty good shape, but then I measure their spirometry and they're well above their predicted value. They're like 110% or 115% of their predicted value. I have no trouble saying they're in a healthy group. Likewise, somebody comes in and they're walking across the ground, they're gasping for air, and I can tell just from as they walk into the laboratory, I'm dealing with a very sick patient. I measure them and they're 40% of predicted on their FEV1, and oh my gosh, we know for sure. We have no question. We have very high confidence that the diagnosis is in that group. But when we get close to that lower limit of normal, or whatever we use to partition health from disease, then accuracy plays a big role. So just a few percent change in an accurate instrument can change your decision from disease to health. So accuracy is extremely important for all those cases that are borderline. Here's a simple example, and you can just kind of read through this. 56, Caucasian male, all right. lower limit normal is this. If the inaccuracy is a few percent, 4%, then Bob can get misdiagnosed, and he gets inhaled drugs for life for a 17.2 milliliter change in a device's readings for FEV1. So here's looking at DLCO. We looked at this in the same series of devices. We looked at spirometry, and we found that if you just look at the different precisions, that's how reproducible the measurements are from one time to the next, then we see big differences when we start looking at either studies or clinical trials and the number of people that need to be in each group to differentiate differences. So if we look here, if we're trying to find a difference of at least 0.05 or 50 mLs, then we're going to see that we need 130 for some instruments, but in instruments that have better reproducibility, we need approximately half of that, or around 70. So in this same study, we looked at DLCO. Now DLCO tends to be more variable and has in the past, and what we're seeing is that in the instruments that had the highest variability, roughly 500 patients would be needed in each group to differentiate just a half a unit of DLCO. And in the very best units, we're looking at roughly 160 patients in each group to differentiate that. And this was in 2007. Now, since then, technology has been improving step by step. And what we see is that here it is again from the previous slide, basically, the number of patients that are needed to differentiate. And if we look here at the 0.05 level, we can see that instead of around 115 for the roughly the best groups in 2007, today, using some of the modern technology, we were examining data from the COPD gene study, which used an NDD easy one, and the variation has gotten much better. So better reproducibility. Therefore, with today's instruments, we can differentiate that same 0.05 with, about 60 patients, which is approximately a 40% reduction in the number of patients to do a study nowadays compared to where we were, a little over 10 years ago. And what factors are involved with this? Faster, more accurate, precise gas analyzers. And this is all technical stuff that technical people and engineers deal with, but they actually worry very, very seriously about reducing the variability and increasing the accuracy of the internal components of these devices. The same goes for the more accurate and precise flow volume measurements. And the new DLCO standards have now demanded new ways of calculating dead space, where you start calculations from, and algorithms and so forth and so forth. Gas calibration and linearization prior to each test is now deployed, and an improved real-time quality assessment. That's where the algorithms underneath say, this is actually sort of meeting the new standards. This is a good test. This is not meeting the standards. It's not. Guides the technician. So in the end, it all helps improve those accuracy and precisions of the devices that are coming onto the market today. Lastly, oftentimes we're asking the question, how long between tests do we have to wait before we can detect a significant decline in a patient's lung function? Now, using an example here from a paper that was in 2005, we see that at 130 mLs variation from test to test in the same patient, and that includes all that noise that's generated by the instruments themselves, that we have to wait approximately 5 years before we can see those fast decliners, those 90 mLs per year decliners. So we're kind of stuck here. But with new instrumentation that is reducing this variability, what we can see now, that's dropped to maybe roughly half of this, and I don't have a slide on this, but if we were to extend one of these, like the 3-year line down, out to about where that 130 would be around 80 or 90 mLs, then we would see we'd be able to detect those fast decliners in COPD within 2 to 3 years. So we've reduced the amount of time that they go without treatment, and we can actually start really being more aggressive with the treatment thereafter. So In conclusion, modern instruments are significantly more accurate and precise than instruments of even just 10 years ago. So the technology is really pushing accuracy and precision to better places. New reference equations are needed to reflect the new accuracies that we now have available of the modern instruments. This is just a call to action, I guess. And the new generation of accurate and precise instruments is now allowing earlier diagnosis of COPD and other pulmonary diseases.
Thank you, Bob, for this nice introduction on the basic criteria for quality of measurement. This is a very important point. The discussion will be at the end of all presentation. So I introduce now the next speaker. It's Professor Helgo Magnussen.
What I would like to bring for you is some technology, but in particular, clinical remarks. Let's go to the first slide. These are my conflicts of interest. And this is a representation, a schematic presentation of the human respiratory system. And you see, this is quite complicated. If a gas is entering the mouth, it should come to the blood, then these gas has to move through very, very different regions which have different resistance to the movement of the gases. And this is the important thing we have to realize. And these are not only the airways and the alveoli. This is always the gas exchange area where the vessels are so important. And we would like to measure the system, the function of the system with only one measurement. And normally this is done with spirometry. But spirometry is not the whole answer for saying the function of the lungs are okay. We need to study the pulmonary gas transfer, and this is not commonly measured. Now, to do this, as Bob said, we have to be confident to the validity of lung function measurements, which is dependent on the equipment, of the advices for the patients, in the performance, and in the interpretation. And here I have one example from our wisdom study. Probably most of you will know this. And in this wisdom study, we measured the triple therapy and the decrease of ICS in about 2,500 patients. And all of these patients had a home-based spirometer from this company, NDD. And the patients are using this spirometer, and we therefore have a high number of measurements in one patient over quite a period of time. This is here about 9 months. And you see, with the density of all these data points, you will be able to calculate a loss of lung function over time very precisely. And the other information is, here you see the rapid decline of lung function after withdrawal of inhaled corticosteroids. This can be sensitively demonstrated. And here again, we have a high number of data points showing that the rate of decline is not decreasing with these two different therapeutic regimens if you have a high number of data points. But also the difference between this line, and that line is about 40 ml. And this difference of 40 mLs is based on the drugs, but it's also based on the fact that the measurements has been done by the patient by themselves. And if a patient is blowing a spirometer, then this is not as good as they are taught by a good advice. This is the reason why we need to have, on one hand, good advice, and on the other hand, good precision in our measurements. Now, as Bob already mentioned, a couple of years ago, the ERS ATS standards for single breath carbon monoxide uptake in the lung has been published, and this was a great step forward. Why? This is the simple measurement of diffusion capacity for carbon monoxide in the lung. What you're doing, you are inspiring a certain volume, and then you have the time of breath holding, and you are inspiring two gases. This is CO carbon monoxide, and a tracer gas, which is helium, which is there to measure the volumes within the lung. Now, during this maneuver, you can have many, many mistakes. Your inspiration is not fast enough, the inspiration is not deep enough, and so on and so forth. The breath holding time may be too short or interrupted, and during exhalation, you have some problems. All these things are registered by the machine, by the NDD machine, and this makes this machine more precise and more accurate to estimate diffusion capacity for carbon monoxide. And the other important new technology within these machines is that in contrast to the machines which we are using 20, 40 years ago, where gas was collected in a bag and then you measure the concentration of the gas in a bag, now the change of the gases during the maneuver are continuously measured and then calculated. And therefore, you have a better estimate of alveolar volume and also a better estimate of the CO uptake. And this is also a great advantage. Now, these rapid gas analyzers, as the name said, they have a response time to a change of gas in milliseconds. And many years ago, this was not milliseconds, but seconds. Now, these are the things we have to be aware of if we should trust our measurement. There should be, the flow analyzer must be zeroing. The gas analyzer must be put on zero. The volume should be checked. There should be biological controls. You should calibrate the syringe, and you could calibrate the syringe leak test, and you should check the linearity. I'm sure that you and your technicians are not very much interested to do this. And this is really the advantage of the new technology. There's a true check technology. This is the face. And all these measurements are done by the machine before any measurements. And the machine will only give you a result of the measurement if all these things are okay. And for a technician and a doctor, this is wonderful. If you get a number, or two numbers, VCO and alveolar volume, then you can be sure that all things which have to be taken into account have already been measured. Otherwise, you will never get an answer. And this is perfect for our daily life practice in pulmonary pulmonary labs, functional, sorry. I will now go in short view about the steps which a gas has to make from the mouth to the capillaries. This is very complex, and therefore I say it very slow. Delivery of the gas to the airways and to the alveolar space. Then the mixing of the gas in the alveolar ducts, the air sacs and the alveoli. Then the transfer from the gas to the liquid phase of the alveolar membrane. And then the mixing and diffusion in lung parenchyma and alveolar plasma. And then finally, a diffusion across the red cell membrane and within the cell. And then the chemical reaction with hemoglobin. All these steps are within our lungs. And all these steps have to be overcome during the transport of the gases into the alveoli. But the diffusion capacity is using this model. And in this model, you do not see these steps. This model is very, very simple. There's one compartment of the lung, and there's one arteria, a vessel, one vessel. And this is all the structure where the calculation is done. And the calculation is very simple, though this may not be, at first glance, very simple, but it is. There is a certain amount of CO, and this certain amount, which changes over time, is dependent of the diffusion capacity and the slope of the decline of CO. This is a story. This is a story. And in order to measure the initial concentration of carbon monoxide after inspiring the gas, because it is then diluted within the lung volume, you need helium. And helium is therefore important to estimate the starting concentration of CO. And this is the so-called complexity of this equation. But it's so simple. but we have only one number, diffusion capacity or the rate constant, and perhaps for sure, the alveolar volume. And with this number, you should then say a decreased diffusion capacity is due to emphysema, is due to pulmonary vessel disease, is due to fibrosis, is due to, this is the problem. This is a problem. With these values, you should think about your patient. You have to use other informations about your patient in order to say the decrease of the diffusion capacity is due to this or that disease. Now, I will focus on emphysema. And you know that the air space in emphysema is enlarged and that the surface area is lower. And therefore, we have problems of mixing of the gases on one hand, and we have problems how the gas transfers through the membranes to the vessels. Now we have a very important thing to consider. If we are using helium and if we are using CO, these gases have a different weight. Carbon monoxide is heavier as compared to helium. And there's a law, the Graham's law, of diffusivity in a gas phase. If CO is going from here to there, then CO is slower than helium, because helium is lighter. And if these two gases are entering the lung, then the equilibration within the lung may change according to the size and the anatomy of the air sacs. And this is very important because you need time for mixing. And many years ago, we have done some experiments showing that in patients with DOCO, the breath holding time is critically important for measuring a real diffusion capacity. That is to say, if the breath holding time is too short, then you underestimate the diffusion capacity for the diffusion capacity in patients with emphysema, and this is not true in patients with asthma, though in some of these patients we induce hyperinflation. And though we induce hyperinflation, this does not occur that the diffusion capacity in asthma is dependent of breath holding time in terms of increasing breath holding times. Now, a good friend of our chairman was Brian Graham. And a couple of years later, he made a similar experiment. And I was very happy that the results were similar. And you see here also, with breath holding time, diffusion capacity for carbon monoxide increases. And the conclusion of this author was, DLCO is limited by the reduced transport of CO from the inspired gas through the alveolar gas prior to coming to the alveolar capillary gas exchange. This is the mechanism why DCO is decreased in pulmonary emphysema. And therefore, we should use this technique if we are investigating patients with COPD in order to get an idea how the transport of gas in patients with COPD is limited and why this is limited. Now, therefore, I'm happy to present you two recent papers. One paper is from Germany, and this is the Corticonet network. And here these authors investigated the relationship of spirometry, body plethysmography, and diffusion capacity parameters in patients where emphysema was diagnosed by CT. And the result of this investigation was, if you say, I have emphysema, yes or no, and you then make this kind of plot, so-called observational receiver operational curve, then you see the following result. That if you combine spirometry with diffusion capacity, then body plethysmography does not give us further and additional informations. Many years ago, we were convinced that body plethysmography is the gold standard in investigating patients with COPD. It's not bad, but if you have the information from spirometry and diffusion capacity and taking into account the alveolar volume, which is also measured by helium dilution in patients with a diffusing capacity measurement, then you do not need body plethysmography in order to describe the functional situation of your patient. Next, very important publication. And also here, Dr. Jensen, one of our chairmen, is one of the authors. In the COPD gene group, diffusing capacity for carbon monoxide was studied for the assessment of patients with COPD. And the objective of this study was to explore whether lower DLCO is associated with greater COPD morbidity, independent of FEV1, in patients, and they will ask the question whether the combination of reduction in DLCO and FEV1 is associated with worse outcomes than either combination in isolation. They analyzed quite a number of patients, about 2,000 COPD gene participants of a very broad spectrum of GOLD stages. And what is for me the most important information, the DLCO measurements and the spirometric measurements were not only measured and said in emphysema is this or that, it was compared with the symptoms of the patients, which is given by the SCAT score, which is given by the SGRQ score, which is given by the SFX-36 physical function test, and also the 6-minute walking distance. And here you see that the combination of diffusion capacity with spirometry is important to mimic and to understand the symptoms of the patient. And that if you combine both DLCO plus FEV1, and both are compared, then you have a really solid information about the functional situation of your patients, and you can relate this to the symptoms you have assessed by these techniques which I mentioned. The conclusion of this author is impairment in DLCO was associated with increased symptoms. That is to say, please do not only measure lung function, ask the patient what kind of symptoms do they have. Reduced exercise performance and severe exacerbations, even after accounting for spirometry and COD evidence of emphysema. And these findings suggest that DLCO should be considered for inclusion in future multi-dimensional tools for assessing COPD. We have to change our attitude when we are faced with the problems of patients with COPD. We should measure DLCO and we should ask for symptoms in a very organized way by using questionnaires. If we say that diffusion capacity is decreased in emphysematous areas of the lung, then we can ask ourselves, what happens if these emphysematous areas in the lung are removed by a surgeon? And this is a so-called lung volume reduction surgery, which is also done in patients with severely impaired diffusion capacity due to emphysema. And here, this is a study from Switzerland, from Zurich. You see what these guys have done. They made an operation here and put this part away, or here, or here, or here, or here. And if they are doing this, the increased lung volume, the relationship between residual volume to total lung capacity decreased, and also DLCO decreased. My interpretation for this is due because we are removing the emphysematous part of the lung, and therefore diffusion capacity is increasing. But there are also other interpretations about this, and it's a great pleasure now to ask my friend Horst Olszewski to give you another interpretation which is related to the vessels within the lungs. Thank you for your attention.